Good morning, this is Dr. Rutledge. And I'm sorry I'm not there with you in Turkey. I wanted to be there, but I made a mistake. My passport ran out of pages, so I have to go back to the U.S., and I'm in India now, and so I apologize for not being there. I hope this presentation will be interesting. I'm going to talk about understanding weight loss after bariatric surgery, and I'm going to point out what I think are some confusion, mistakes, misunderstandings, and see if that can be valuable in our talk this morning. First, I'm going to just refer briefly to the fact that the mini-gastric bypass is an excellent procedure. You just have to look at the data to see that the MGB is really a good choice and really outperforms the band and the sleeve and the Roux-en-Y and the BPD, SATI type operations by quite a bit. Then I'm going to point out that the mini-gastric bypass is widely misunderstood, and this confusion is persistent. And I'm going to use just a couple of examples today in my talk. One, I'm going to talk about the biliopancreatic limb length. And recently, there have been a variety of errors. Like one surgeon has written that the length of the bypass doesn't affect weight loss, which is wrong. And we can explain that with what's called a type 2 error, which we'll go into in detail if you wish. And then we're going to talk about the new onset of fear of malnutrition after the MGB. And we'll point out, for example, that the MGB rates of malnutrition are similar to the Roux-en-Y. It's a lot of confusion about that. And then we're going to talk about mismanagement of MGB malnutrition, because malnutrition in the Roux-en-Y, the MGB, the biliopancreatic diversion can occur. MGB is relatively uncommon and can be managed easily if you understand what to do, but we've seen where published papers of surgeons mismanaging it, and the most obvious example is where people have a patient with malnutrition after MGB and they convert it to a Roux-en-Y, which is performing a weight loss surgery for someone who's lost too much weight. So anyways, we'll talk about that briefly. And then we're going to point out that all this confusion suggests to me and to my colleagues and to a group of friends that the MGB needs standardization so that we can do better education and recognition of surgeons who understand and perform the mini-gastric bypass in an excellent way, and then provide patients with an access to these surgeons. MGB, I put a video up on the International Bariatric Club, and Harris Quadja got all angry because I put down MGB best bariatric surgery, and he got all upset about it. And I don't know, it's my opinion. In hundreds of articles of the MGB, it's interesting. In every study, by every measure, the MGB is at least equal to and more often better than any other comparable bariatric surgery. And this includes when it's been compared in controlled randomized prospective trials. So, obviously I'm biased, but I would say if you look at the data, there's no surgery that's better than the MGB. But of course, you shouldn't use it if you don't understand it. And we've seen a lot of people who get confused about the operation and have harmed themselves and others because of this widespread and persistent misunderstanding of the mini-gastric bypass. And this has led to complications and even death. And of course, this argues that we need to standardize it, do better education of the MGB around the world. And we're trying to get an organization to do just that. We need to standardize, recognize those surgeons who have the best skill and knowledge. And so we're working on creating what we call the MGB Review Corporation, and you, of course, are all invited to join us. If you want to become a member of the forming Board of Governors, we have a link here. You can join our Facebook page, and don't hesitate to call or email me anytime if I can help. How often have surgeons been wrong and continue to be wrong? I mean, the list is so long, but I'll just give you a couple of examples. Many people told me for 20 years the pouch is too big and the anastomosis is too wide, so patients won't lose weight. Well, they were wrong. Many people thought that you could do and still do a short gastric pouch, essentially making the MGB the equivalent of the old Mason loop, and that's wrong, and we still see that complication and misunderstanding. Many surgeons who come to the MGB come from a background in Roux-en-Y or sleeve in particular, so they dissect the EG junction and want to repair the crura. That's wrong, in my opinion, for an MGB. Some surgeons have put a ring on the MGB, although most of them have found trouble and have stopped that. Irrational fear of bile reflux and confusion about gastric cancer have been widespread, although that seems to be declining. And recently we've seen a rise of fear of malnutrition and misunderstanding about how to manage complications. So we're going to talk about those two, in particular the first one, malnutrition, this morning. So one of the things that is part of this confusion, there's been confusion about the bowel bypass limb length and weight loss. Okay, and there have been studies of the Roux-en-Y where they varied the Roux limb and the biliopancreatic limb, and those studies have been mixed. Some have shown no advantage of changing the biliopancreatic limb length and weight loss, and so that's confusing. And there's a surgeon, a prominent surgeon, very smart young man, who said that you should never do an MGB longer than 150 centimeters. And his justification is the MGB at 150 gets less malnutrition, which is correct. But he also then made that same type 2 error. He said 150 equals the same weight loss as 200, and that's wrong. And we'll go through some of that in my presentation this morning. So what we're going to talk about are three things: the biliopancreatic limb and weight loss. And I'll tell you the findings now here. You can actually fall asleep for the rest of the presentation if you just remember this slide. This is all there is to it. So biliopancreatic limb and weight loss, here it is. Longer bypass is more weight loss. Hello, it's simple. We can go into details and the science on it, but that's the bottom line. Malnutrition and MGB, here's the bottom line. It's uncommon and easily managed. And the MGB is unique in that the surgeons and the patient can choose to make the MGB more powerful for greater weight loss, or they can choose to be more conservative to decrease the risk of excess weight loss, keeping it as low or lower than the Roux-en-Y, for example. And the management of excess weight loss after MGB is also easy. Basically, there's a pre-op preparation of the patient and the surgeon to understand the operation. In the event that it occurs, it should be recognized early, resuscitated, and early or immediate revision that takes only 30 to 60 minutes. And in particular, don't do a weight loss surgery for extra weight loss because you've got too much weight loss. And so don't do a Roux-en-Y. Okay, number one. So that's it. That's the whole talk. Again, you can kind of check out now, check your cell phone and see if you're getting any likes on Facebook. But let's go through those three things and see if I can provide adequate background, because there are a lot of people who disagree with those things and they're incorrect, and see if I can give you the data on this so you can be clear. One is the biliopancreatic limb length and weight loss. And here's the answer: the longer the bypass, more weight loss, period. So this is my study. I've got now over 4,000 patients who've done the follow-up, 6,000 patients, and about 2,000 haven't answered. But in short, the longer, no pun intended, the longer the bypass, the more weight loss. That's all there is to it. This is the linear regression line for bypass limb length and weight loss. The more the bypass of the gut, the more weight loss. It's really simple. It's not perfectly accurate. In other words, there's a large standard deviation, but this is really simple. If you bypass more, the patients on average lose more weight. And here's a three-dimensional plot because those who are heavier lose more than those who are thinner. But here's the truth of it, which is there's a lot of scatter. So even though there is a mean and progressive change, the individual patient can be all over the map. And that's a sad truth of all the weight loss surgeries, and we'll talk about that later. So my study there, which was rejected by some of my colleagues in America, is the largest study of bypass length and weight loss. And the other studies have been negative because they had a type 2 error, which meant that they had a small sample size, which they felt that it showed no difference, but it was small because they had a small sample and high variability. So basically, for every additional foot of bowel bypass, there's a mean increase in the expected 1-year weight loss. So again, here's the simple conclusion. Longer bypass, more weight loss. In other words, this is incontrovertible. It's not true in every patient because of the scatter, the standard deviation we'll talk about, but longer bypass, more weight loss. Longer bypass means more power, but as you create greater power, you increase the risk that you'll have excess weight loss. But it's small, and we'll go over the details of this. But here's the simple answer. You bypass more, you lose more weight. All right, now what about malnutrition? Uncommon and easily managed. In other words, here's the conclusion. It's uncommon and it's easily managed if you know what you're doing. But the MGB is unique because preoperatively, the surgeon and the patient can choose either more power or lower risk. And there are pros and cons, of course, to each approach. But recently, the literature has been filled with kind of fears about malnutrition after MGB, so let's look at the data. Here's an example where I just pulled a few of these articles: impact of biliary limb length, malnutrition, severe fatal malnutrition, laparoscopic reversal for severe malnutrition, and malnutrition. So this is one of dozens of articles that have suddenly appeared. And so you might say, well, I'm a little frightened. What about malnutrition and the MGB? And obviously there's some of these surgeons with some hyperbolic terms and discussion. And so let's get the truth of it. Okay, this again shows pretty deep misunderstanding of the MGB, because the data, as I'll show you, show that malnutrition after the MGB is uncommon and easily managed. It's a misunderstanding of the Roux-en-Y, because the Roux-en-Y data shows it has similar risk of malnutrition, and it's harder, more dangerous, and more deadly to revise. And it completely ignores the data on SATI or BPD, which has much worse rates of malnutrition, but seems to not have the same hue and cry. But most important, if you just understand some simple statistics, you'll be able to understand the association between more powerful surgery like Roux-en-Y and MGB and BPD and malnutrition. And as far as I can tell from all the published papers, nobody understands this fifth point here. And you'll be able to understand it, I think, at the end if I do a good job. So here's an example of one of these scary papers that said this case series, which was 12 patients and 7 had MGBs, which they weren't sure whether it was an OAGB or an MGB or what the difference is or whether they're the same. But they're very confused. This case series suggests that OAGB, which is now an MGB plus OAGB, could overexpose subject to severe nutrition complications. Ooh, yeah, it's scary. But in their article is none of the following data. So let's look at what they could have looked at before they wrote their paper. What we would argue is fear of MGB malnutrition in a paper like that shows ignorance of the large-scale MGB series. So, for example, I'm going to give you just 2 series. I could give you dozens more, but every single large-scale MGB series shows the same, that malnutrition after MGB is low and treatment is easy if the surgeon knows what they're doing, and oftentimes we see the surgeon does not, and that leads to complications and death in some cases. So hopefully this presentation will help you if you get interested in this topic. This is an example from 2016. It's from Dr. Lee. Out of 2,380 cases, he had 49 that had to be reoperated for conversion of some kind. And what they found is the rate of conversion was 2%, a little over half were malnutrition, so that 1% of MGBs had revision for malnutrition. Okay, 1%. Okay, here's another study. This is from Chevalier. He had malnutrition requiring revision in 1.6%. So 1.6. Now, here's another article. And this is an article where they were surveying, and the conclusion in the abstract and all this is talking about danger of malnutrition. But the study is 100 surgeons, 36,000, almost 37,000 patients, and they report the malnutrition rate is 0.4% or 138 patients. Yet this article in 2017 doesn't say that malnutrition is uncommon, 0.4%. It says it's worrisome and has advice about the biliopancreatic limb length. So it's malnutrition in this study, where they raised concerns about malnutrition, was found in 0.4% of patients. So 1.4, it's uncommon, and if you know what to do, it's easy to manage. Okay, let's go forward a little bit more. Again, 100 surgeons, almost 40,000 patients, malnutrition rate 0.4%. Now, I'm going to show you the data. That's between 5 and 10 times lower than reported for Roux-en-Y, and maybe even 50 to 100 times lower than SADI. And this is from Dr. Mahawar. So I think it shows little recognition of the fears of the MGB rate data, even in the same article. And it doesn't have any comparison in these studies that I've seen to the Roux-en-Y versus the MGB. So this is a deep misunderstanding because in summary, Roux-en-Y has malnutrition revision rates roughly equal to the MGB, which is not mentioned in these kind of scary articles. So PubMed, just as a start, this is really simple. You can do this at home in 5 minutes. Is you search PubMed for Roux-en-Y gastric bypass, you'll find almost 12,000 articles. If you say Roux-en-Y gastric bypass plus malnutrition, you'll find almost 500 articles. So close to 4% of all Roux-en-Y articles ever published talk about malnutrition. And I'll show you some of those several hundred articles just for fun. In addition, if you do Roux-en-Y plus deficiency, there's 514 articles. So there's a lot of problems and publications about Roux-en-Y with malnutrition and deficiency, which the MGB fear of malnutrition people don't reference at all. So here's 4 out of the 400. So here's severe protein calorie malnutrition after Roux-en-Y, 2016. Reversal of gastric bypass for severe malnutrition in the Roux-en-Y, 2015. Risk of malnutrition, trace metal, vitamin D deficiency, post-Roux-en-Y, gastric bypass, 2015. And malnutrition and myopathy in Roux-en-Y, and 400 more articles that I haven't, 470 more articles that I didn't list. Let me say, in brief, they all say about the same thing. Here's one that I think got my attention. This is from the University of Virginia, which is a very well-respected hospital in the United States. They just looked at feeding tubes, and they looked at their Roux-en-Ys. They found that 4% of their Roux-en-Ys needed a feeding tube. Now, that's bad. In other words, if you had some signs of malnutrition, which would be hypovolemia, peripheral edema, you could revise them. But if you have to put in a feeding tube before you can do anything, that's bad malnutrition. And in this case, they reported 4%. And that's just the ones that came back for follow-up at their hospital. This is not good. Here's an IFSO president, Dr. Hempens, 2017. He talked about his experience with Roux-en-Y side effects, and malnutrition was common in that group in the medium term after their errors and problems. Here's a systematic review. Systematic review of 35 articles, malnutrition, the most common indication for reversal, 2016. The most common procedure needing TPN, this is a Journal of Parenteral and Enteral Nutrition, said TPN post-bariatric surgery, most common procedure needing TPN was Roux-en-Y in what, 2/3, 3/4 of patients. And this is a study that just showed the decreasing albumin, pre-albumin, in Roux-en-Y and sleeve was about the same. They had comparable effects on the micronutrient protein deficiency, so it wouldn't be too surprising to me if the sleeve turns out to have a similar risk of malnutrition, although it's probably slightly less. Finally, this one I thought was interesting because of the BMI in this group was found to be around 14, so that's pretty low, pretty severe malnutrition. And then none of these papers that raise fears of malnutrition after the MGB talk about the SADI, and the SADI is now really growing in interest. And in this study, they found 1 out of 3 had malnutrition. So systematic review, this is published in 2017, systematic review of efficacy and safety, malnutrition in up to 34% of patients. This is in 500 SADIs, almost 600. So this is bad, but I mean, all I'm saying is MGB, what are we worried about malnutrition? You should worry about SADI or Roux-en-Y. Okay, so we have 2 things that show that the present little rush of fear about malnutrition is kind of basically ignorance or confusion. But it's even more obvious than that. All you have to do is look at the statistics. And let me see if I can explain this to you simply. All right, I'm going to talk to you about the Roux-en-Y, the MGB, and the VPD. Okay? If you look up 20 or 30 articles on each one of these, as I did, you can come up with an average excess weight loss. And you could argue with this, but I gave the benefit of the doubt to Roux-en-Y, said that their average excess weight loss 72%, maybe less. MGB 78%, maybe a little less. And we gave the SATI people 82%, again, maybe a little less. But then if you look at the articles that average their standard deviation, and remember what standard deviation is. If this is the mean, this is the spread or the accuracy. And interestingly, for all of these studies, if you keep looking, they keep coming up with standard deviation about the same range between 20 and 25%. Now for the graphs I'm going to show you, I said let's assume that if these patients in this group here lost all of their excess body weight, all of the excess, got back to normal body weight, and then lost an extra 20%, that's a pretty high indicator that they're going to have malnutrition. In other words, they lost everything plus another 1/5 of their body weight. That's probably a risk of malnutrition. And you could adjust this, but for sake of argument, go along with me because it'll explain everything, I think, as far as these kind of somewhat silly articles. So if you use this mean plus standard deviation, it's easy to predict the expected rate of malnutrition with just simple statistics. And let's see if I can show this to you. So here's Roux-en-Y. Imagine that their power of excess weight loss is around 72%. So if you say people would lose, on average, 72% of their excess body weight, and then our question is, what percent will lose more than 120? And this comes out to be about 1.8 or about 2%. Okay? And you can say that's good or bad, but it's in the range of the published series. So let's say this again. I don't have to do any scientific research. If I know the mean and the standard deviation, if I know the mean excess weight loss and the standard deviation, I can kind of guess how many people are going to get malnutrition. And I'm going to guess, on average, for most Roux-en-Ys, 1 or 2% are at risk because they're going to lose more than 120% of their body weight. Okay? And that matches the clinical data. But now this explains it to you because when you get a mean of here, it means that some people lose too much and some lose too little. Okay? That's what the standard deviation means, which the writers of these other articles kind of, I think, have forgotten. Now, if you got MGB, and let's say MGB is a little more powerful than Roux-en-Y. Maybe it is, maybe it isn't, but for this purpose, I said some of the articles, it's a little more powerful than the Roux-en-Y. Maybe not much, but seems to be more stronger over the longer period. And standard deviation is interesting, it's similar, and this would give it a slightly higher risk. So instead of having 1.8%, it would have around 3% higher risk. But we're going to talk about something important, which is the MGB can be tailored. So we'll come back to this. But if we go back on this, you don't have to look up any scientific papers. You can just go back and say, oh, if the MGB is more powerful than the Roux-en-Y, the risk of excess weight loss will go up a little bit. So instead of being 2%, it might be 3%. And this might not all result in malnutrition, but it's for our purposes, for you to try and understand why malnutrition occurs. Because if you get more powerful, as you get closer to 100% excess weight loss, you push the standard deviation down here, more people are going to end up losing too much. And here's an example of that. Here's the SATI. Let's say they lose 82% and some they report 100%. If the standard deviation here is 24%, that means almost 6% would be at risk of losing 120% of their body weight. So now all of a sudden, this was going to be more severe. Now, we saw in the clinical data, it might be even higher. But what we're trying to do here is explain that if you have great power and the same standard deviation, then you're going to increase your risk of excess weight loss. It's as simple as that. But here's the important point. The MGB offers surgeons a unique choice. They can choose to have the great power of the MGB, or the family and the surgeon and the locale can decide, well, we want to be more conservative, and that option is available to you. So, just as an example, you could choose a more powerful MGB with 200 centimeter bypass, and that would give a probability, depending on how we determine it, but survey data, scientific data, research data as well as prediction from statistical analysis say probably with a 200 centimeter bypass, you're looking at 1 episode of malnutrition per 100 patients. That's the risk. Maybe less, depends on the patient, etc. If you want to be more conservative, you could do 150 centimeters. And the guess on that from the data and surveys and from my own study is probably about 1 in 1,000 will have excess weight loss. And so in the hands of the MGB surgeon is the opportunity to choose to be more or less aggressive, and discussion with the patient and discussion about the event. So here's an example. Imagine that you have a 50-year-old diabetic, and let's suppose his diabetes is severe. His glucose is high, his insulin requirements are sky high, and he has evidence of diffuse end organ damage. Let's say he's going blind in one eye, and he's lost sight in the other eye. Let's say he has gangrene in 2 toes and ischemic-looking damage in both feet, putting him at risk of one or both of feet or legs being lost. Let's imagine that he's had 2 previous MIs, a stroke, a TIA. And what if the local physician calls you, the cardiologist calls you and says, I predict he has a high risk of dying this year? In my opinion, you could discuss the options with the family, but I might consider choosing an operation with a little bit greater power because I would like a more rapid and more significant resolution of his comorbidities to protect him from further end organ damage. More end organ damage and he might be completely blind. More end organ damage and his MIs may progress to death with cardiac damage. Further CVA and maybe the patient is permanently incapacitated and unable to work and care for his family. So I might discuss with the family and say a 200 centimeter bypass in my mind is reasonable. I think the risk of 1 in 100 of getting excess weight loss is present, and we can fix it if it occurs, but given his risk, the associated danger of your disease, I might discuss with the family being more aggressive. And I would make sure that was included in the permission form and that I had discussed these issues with the patient ahead of time. Conversely, suppose you are faced with a young female with a BMI of 40. Maybe there's a risk of poor follow-up. What if she's otherwise in good health? Maybe she is or is not a vegetarian. It might be you would choose in that person to be more conservative. You would explain that the chances that the patient will get all the weight loss they like would be less, because weight loss will be less with a shorter bypass. But that the chance of excess weight loss and malnutrition will occur will decline to maybe 1 in 1,000. And all of these are only estimates. But you can see in the hands of the patient, the family, is the opportunity to decide, to choose which they believe is risk. The MGB allows the patient and the surgeon to titrate the operative choices based on preferences and just secondarily to address the post-op excess weight loss or malnutrition easily. And we found this same data in a survey. I won't go over it, but basically we found the survey data matched the statistical data, which matched the large-scale data, which matched my personal series. And that is, for maximal weight loss, you can go to 2 meters, sometimes even more, although that increases your danger. With 1.5 meters, you get a lower risk of excess weight loss. Now, what should you do? I won't spend too much time on this, but here's a good study where they took patients who had conversion to Roux-en-Y, and they said almost half developed major complications. And so they said the conversion of MGB to Roux-en-Y for malnutrition is really dangerous. Well, hello, if you have a patient who has too much weight loss, converting them to a weight loss surgery is a bad idea. So we can talk about that another time, but don't do weight loss surgery for excess weight loss. Anyways, this is my short list, and maybe we could talk about this if you want to call. I could hopefully be there live with you. But if you have a patient with excess weight loss after MGB, immediately assess the nutritional status, resuscitate the patient, and early surgical revision, which is a 30 to 60-minute procedure, should be done, and I don't recommend you delay this much. The classification of malnutrition deficiencies after MGB, we say 90% usually present as delayed presentation. They refuse to come earlier, and they are often sick. In that case, we recommend dividing the gastrojay and performing a gastrogastrostomy, which essentially undoes the procedure, and the operative time is 30 to 60 minutes. When the disease is mild, when there's mild decline in the albumin, mild edema, mild fatigue, etc., it's possible to consider shortening the bypass, but it may not be curative. Again, the operation is easier. But whatever you do, what we recommend is do not do weight loss surgery for excess weight loss or malnutrition. I personally have had consults on such patients who went on to die when they had that treatment by other surgeons. So I'll stop there. I hope that that summary was worthwhile, and I appreciate the invitation to speak, and I'm sorry I wasn't there with you.